I am Dr. Pallavi, DRND PDT of Critical Care, and today the topic of my presentation is Clinical Nutrition in ICU, Recent ESPEN Guidelines. The part 1 I am representing here, and the next class will include the part 2 of the ESPEN Guidelines. The nutritional support is an integral part of the organ support system in case of any intensive care unit. So it includes a systematic and protocolized approach as well as individualized plan of any individual who is critically ill and is admitted in the intensive care. The European Society for Clinical Nutrition and Metabolism, it has given guidelines for enteral and parenteral nutrition on the years 2006 and 2008 respectively, and the recent ESPEN guidelines have been modified on the year 2015. It includes who are the patients at risk, how to assess nutritional status of an ICU patient, how to define the amount of energy to provide, which route to choose for nutrition, how to adapt according to various clinical conditions, when to start the clinical nutrition, and how to progress in the administration of adequate provision of nutrients. There are different definitions and terminologies included in the ESPEN guidelines in the 2015 modification. Firstly, medical nutrition therapy. It is a term that encompasses oral nutritional supplements, enteral nutrition and parenteral nutrition. The two latter have traditionally been called as artificial nutrition, but this term is suggested to be replaced by medical nutrition therapy as a whole. Actual body weight is the body weight measured during hospitalization or reported just before hospitalization. Ideal body weight is weight with respect to the height of the patient, and from ideal body weight and actual body weight we can calculate the adjusted body weight from this formula I have written here. Adjusted body weight can be calculated as actual body weight minus ideal body weight into 0.33 plus ideal body weight. Next, depending upon the calorie
the calculation will be based on what? Adjusted body weight.
Yes, sir. For the recent ESPN guidelines, all the body weights used are ideal body weights. For obese individuals only, we have this terminology, that is adjusted body weight.
Only obese?
Only obese individuals. And other guidelines, how much ideal body weights based on ideal body weight. So should I continue?
Plus 1/3 pulse. I was trying to get out.
Next, depending upon the caloric requirement in the diet, it can be classified into 3 or 4 broad categories. Isocaloric diet is an energy administration of around the defined target. And what is the defined target? I will be discussing it on the recent guidelines recommendations. Next is hypocaloric or underfeeding. It is an energy administration below 70% of the defined target, whereas overfeeding is energy administration of 110% above the defined target. Trophic feeding is a new term in this recent ESPEN guideline, which is a minimal administration of nutrients having beneficial effects, such as preserving the intestinal epithelium, stimulating secretion of brush border enzymes, enhancing immune function, preserving epithelial tight cell junctions, and preventing the bacterial transformation. And the last is low protein diet, which is protein administration below 0.5 gram per kg per day. According to this protein requirement in the diet we have supplemented to our critically ill patients, the protein diet depends on the stress of the patient, whether the patient is having any kind of stress or without any stress. If the patient is having no stress, then the recommended protein in the diet is 0.7 to 0.8 gram per kg per day. If the patient is in mild stress, then it is 0.8 to 1 gram per kg per day. In case of moderate, it is 1 to 1.2 gram per kg per day, and above 1.2, around 1.3 in this recent recommendation. That is moderate to high protein diet, which is recommended in our critically ill patients in intensive care. As I have discussed in the previous slide, underfeeding is energy is less than 70% of the defined target energy administration. There are different signs of underfeeding. That early signs include hypoglycemia and hypothermia, whereas the late signs include infectious complications, impaired immunity, impaired wound healing, loss of fat and lean body mass, and impaired muscle function. Whereas the overfeeding, as I have already discussed, it is energy administration of 110% or above from the defined target. It has some definite early signs like hyperglycemia, hyperlipidemia, hypercapnia, and the late signs are infectious complications, impaired immunity, liver steatosis, increased fat mass. Next, I am discussing the ebb phase and flow phase. Ebb phase is an ancient term which has been modified in the recent ESPEN guideline into various subgroups. Ebb phase is defined as the hyperacute phase when the patient is uh, presenting firstly during the hospital admission or the ICU admission. Hyperacute phase includes increased massive rate of energy expenditure of the patient, and it can be further classified into an early period acute phase and an early period late phase. Late period acute phase. For the first days of 1 and 2 of the ICU admission, this is acute phase early period, and from the days after the second day of admission, there starts the acute phase of late period. In both these periods, the anabolism is less and the patient is already in the state of energy expenditure. There may be hemodynamic instability and the patient may be requiring initial resuscitation before starting any kind of clinical nutrition. Next, the phase is late phase or rehabilitation or chronic phase, which is anciently termed as flow phase. Flow phase, their anabolism gradually increases and the rehabilitative measures of the body and also the metabolic requirements also improves as per the clinical condition of the patient. So ebb phase and flow phase, these are ancient terms which has not been used in the recent ESPEN guideline. Rather, they have classified the whole period of ICU admission in these three phases, like acute phase early period, then acute phase late period, and then late phase. Next, I am discussing the recommendations proper. Clinical question 1. So, who should benefit from medical nutrition? Who should be considered for medical nutrition therapy? The recommendation says it is a strong consensus that is medical nutrition therapy shall be considered for all patients staying in the ICU, mainly for more than 48 hours. But if the patient is very much hemodynamically unstable, then we should first initially resuscitate the patient. After gaining initially the hemodynamic stability, we should start or we should look for the probable options available for the clinical nutrition. But low dose vasopressor is not a contraindication to start clinical nutrition in any critically ill patient. If the patient is on low dose inotropes, we can still start looking for options to use in case of clinical nutrition. Next is how to assess malnutrition. The recommendation to it is also a strong consensus. It says a general clinical assessment should be performed to assess malnutrition in the ICU until a specific tool has been validated. I am discussing different clinical assessment rating scales and also the scoring systems in the next slide. Global assessment of nutritional status, it includes different parameters like history, physical examination, and also the subjective global rating. History includes weight change. These history related, physical examination related, and global rating related main scores which we use in our scenario is Nutric score, that is nutrition in the critically ill patients scoring system, and NRS score of 2002 year. NRS is nutrition rating scale of 2002. The history includes weight change, dietary intake change than normal, GI symptoms persisting for more than 2 weeks, functional capacity, and disease specific requirements. Physical examination is loss of subcutaneous fat. Muscle wasting mainly we look in quadriceps and deltoid group of muscles. Next, presence of ankle edema, sacral edema or ascites. And subjective global rating is either the patient is well nourished or the patient is moderately or severely malnourished. This slide shows the Nutrix score. Previously in 2006 and 2008 ESPEN guideline, they included IL-6 as a parameter of Nutrix score. But in the 2015 to 2018 modification of ESPEN, they have removed the IL-6 parameter from the Nutrix score. I will be discussing both. Nutrix score variables are age, Apache 2 score, SOFA score, number of comorbidities, and days of from hospital to ICU admission, and as well as IL-6, interleukin 6. Age less than 50 is 0, 50 to less than 75 is 1, more than equal to 75 is 2. Apache 2 score less than 15 is 0, 15 to less than 20 is 2 or 1, 20 to 28 is 2, and more than equal to 28 is 3. SOFA score less than 6 is 0, 6 to 9 is 1, and more than equal to 10 is 2. Number of comorbidities 0 to 1 is 0, and more than equal to 2 is 1. Days from hospital to ICU admission 0 is 0, and if it is more than equal to 1, it is 1. IL-6, they have removed it from the criteria of recent ESPEN guideline, but till 399 of IL-6 it is 0, and more than equal to 400 is 1. Whereas the previous guideline included if IL-6 was available as a parameter, the low score is 0 to 5, then the patients have a low nutritional risk. If the score is 6 or above, then the patient is associated with worse clinical outcome, and the patients are most likely to benefit from aggressive nutritional therapy. Whereas the IL-6, if it is not available as in the recent guideline, the scores, some of the point only 0 to 4 and more than 5, 5 or more. 0 to 4, the patient has low nutritional risk, and 5 or more, these patients are more likely to benefit from aggressive nutrition therapy. This is Nutritional Risk Screening Score or NRS score of 2002. This also includes two types of categories like nutritional status and disease severity. When we calculate the total score, total NRS score is nutritional status score plus disease severity score. Nutritional status score can be further classified as no risk or no malnutrition, mild, moderate or severe. Mild is weight loss more than 5% in 3 months, or intake of food intake of in the last week was 50 to 75% of the normal. Moderate is weight loss more than 5% in 2 months, or there is another criteria in ESPN guideline that is more than 10% is in last 3 months. BMI is 18.5 to 20.5 and reduced general condition with normal food intake 25 to 50% of the normal food intake in the past week. Moderate. And then severe is the weight loss is more than 5% in last 1 month or more than 15% in last 3 months. BMI less than 18.5 with reduced general condition, and 0 to 25% of the normal food intake in the last week. Whereas the disease severity is concerned, mild disease severity is if the patient is suffering from hip fracture, chronic disease, especially with complications like liver cirrhosis, COPD, cancer, diabetes. If the patient is on chronic hemodialysis, these are included in mild disease severity. Moderate disease severity include stroke, hematological malignancy, severe pneumonia, and extended abdominal surgery. Whereas the severe disease severity includes head trauma, hematopoietic stem cell transplantation, and intensive care patients with Apache 2 score more than 10. If the patient is having advanced age, like age more than 70 years, then we have to add +1 into the total NRS score. 0 to 2 points is if the total score is 0 to 2 points, then we have to repeat the screening every weekly. And if the score is 3 or more, then the patient is at nutritional risk and nutritional care plan should be set up.
Mild is 1, moderate is 2, and severe is 3 points.
Mild is 1, then moderate is 2, severe is 3. একই রকম ভাবে ডিজিজ সিভিয়ারিটিতেও মাইল্ড ইজ 1, মডারেট ইজ 2 and severe is 3. Clinical question 3. Then how to screen for the risk of malnutrition during hospital stay. Every critically ill patient staying for more than 48 hours in ICU should be considered at risk for malnutrition. Then when should nutrition therapy should be initiated and which route to be used? There is a dictum, if the patient is able to eat, then we should go for enteral nutrition or oral feeding. We should be preferring oral feeding over enteral or parenteral nutrition every time if the patient is able to eat. That is the recommendation 3 is saying the oral diet shall be preferred over EN, that is enteral nutrition or parenteral nutrition in critically ill patients who are able to eat. If oral intake is not possible, then early enteral nutrition within 48 hours in critically ill adult patients should be performed or initiated rather than delaying the enteral nutrition. Another recommendation is early enteral intake within 48 hours should be performed rather than early parenteral nutrition. If the patient is not able to eat, then we should try for early enteral nutrition, not early PM. In case of contraindications to oral or enteral nutrition, what can be the contraindication? Patient may be unable to eat. There may be history of abdominal distension. There may be history of gastric intolerance. There may be intolerance to enteral feeds with history of repeated bloating, nausea, diarrhea. This can be there. Then parenteral nutrition should be implemented within 3 to 7 days. Early and progressive parenteral nutrition can be provided instead of no nutrition in case of contraindications for enteral nutrition in severely malnourished patients. Contraindications of enteral nutrition I have already discussed. To avoid overfeeding, early full enteral nutrition and parenteral nutrition shall not be used in critically ill patients but shall be prescribed within 3 to 7 days. Now, to avoid overfeeding, sir, overfeeding is more than 110% of the estimated target. If we are administering energy of more than 110% to the patient, then there is a chance of overfeeding as well as refeeding syndrome. If the patient is in the first few days,
shall not be used in critically ill patient, but shall be prescribed.
আর্লি মানে স্যার হ্যাঁ প্রথম 1 থেকে 2 দিন যেটা সেটাতে আমি ফুল পিএন দেব না বা ফুল ইএন দেব না we will start with the energy requirement at least 25 to 50% দিয়ে আমরা স্টার্ট করব then we will gradually increase the total food intake total nutritional intake in the next after the third day within the first few weeks we will be reaching the target but not for the first 48 hours we will not be giving the full dose. Next is in adult critically ill patients, does intermittent enteral nutrition have an advantage over continuously administered enteral nutrition? The recommendation is we should use continuous enteral nutrition rather than bolus enteral nutrition. In adult critically ill patients, does post-pyloric enteral nutrition compared to gastric enteral nutrition improve outcome like reduce mortality or reduce infections? There is no significant data regarding the mortality. We should avoid the post-pyloric feed or we should always try to go for gastric feed. It's not like there is no clinically the relevance is not much, but the gastric axis should be used as the standard approach if the patient is able to tolerate. In patients with gastric feeding intolerance not solved with prophylactic agent, post-pyloric feeding can be used. post-pyloric feeding that can include nasojejunal feed or like this. Other than nasogastric or gastrostomy tube, we can go for nasojejunal tube or post-pyloric feeding. In patients deemed to be at high risk of aspiration or if there is airway protection is in question, then post-pyloric feed, mainly jejunal feed, can be performed. Does the administration of prokinetics improve outcome? Like prokinetics can be used like metoclopramide, erythromycin. Intravenously, they can be used as a first-line prokinetic therapy if there is history of gastric feeding intolerance. But only the gastric feeding intolerance, if the patient is having intolerance to enteral feeds, we should not only use like erythromycin or metoclopramide. We should firstly assess what is the cause of that intolerance to enteral feed. If there is any other cause of this diarrhea or of this nausea, vomiting, we can also look for Clostridium difficile infections like this. If all the causes have been excluded, then we should start with the prokinetic therapy. And still, if the patient is not having proper tolerance to feed, we can reduce the amount of feed we are giving to the patient. Next is how to define the energy expenditure.
What is the dose of erythromycin?
The IV erythromycin is very incredibly rates. So normally saying that say if you have to use macrolide intravenously, you want to use chlorantraniliprole. But the recommendation for prokinetic activities for erythromycin. IV is a bit of a dodgy thing. It's macrolide I think most people would use metoclopramide. Leave the tube in for 48 hours, and while the rest of the activity, you'll find that it has gone down.
Yes.
Or you can take the help of your gastroenterologist to your post-pyloric place.
If in case of assessing the tolerance to enteral feeds, we should be assessing the residual volume also. When we are giving the enteral feed to the patient for the initial few hours, we would be assessing the gastric aspiration amount every 2 hours. And when the feed is being continuously given, then we should assess it every 8 hourly. If the residual volume is more than 200 ml per day, then we should think of shifting the patient to any post-pyloric feed or any other mode of clinical nutrition.
Sure. What I'm trying to say is that when you go for post-pyloric, then you have to place it post-pyloric. So sometimes if you have a fracture which has a guide bar, makes it stiff, it is easier to place it. Sometimes it doesn't go, but you can leave it in the stomach and you can use something like metoclopramide for 48 hours and the rest of the activity will move it down. So if you do a repeat X-ray after 48 hours, you'll find that the tube has gone in. If that doesn't happen, then you can ask your gastroenterologist to place it. Indication of when you are going to place a post-pyloric sugar dosage. Intravenous erythromycin is a bit of a dodgy thing. Intravenous erythromycin erythromycin is the vein-friendly macrolide you have to do. Erythromycin is what Baba tell us.
So what I remember the dose is 250 OD.
Yeah.
And it's 200 ml in 24 hours or in single aspiration?
Single aspiration.
Not in 24 hours. And that also need to go for syringe aspiration rather than go for suction.
How to define the energy expenditure? In critically ill mechanically ventilated patients, energy expenditure should be classically determined by using indirect calorimetry. If indirect calorimetry is not available, then we can use oxygen consumption, that is VO2 from pulmonary arterial catheter, or carbon dioxide production from, that is VCO2, derived from the ventilator, and we can assess the respiratory quotient. Respiratory quotient is ratio of volume of carbon dioxide liberated divided by volume of oxygen consumption. If it is more than is equal to 1, then the patient is having maximum energy expenditure, and we should assess and we should modify the clinical nutrition regimen of that patient. But if the patient is on prolonged ventilation with high FiO2, or if there is high suspicion of air leaks, then respiratory quotient is not a good parameter. Then we can use the abbreviated Weir equation to calculate REE. REE in kilocalorie per day can be calculated in this equation, like 3.94 into volume of oxygen consumption plus 1.1 into volume of carbon dioxide liberation whole into 1440 ml per minute. That is resting energy expenditure. Next, I am discussing the refeeding syndrome. As I have discussed, the patient should be regularly assessed for tolerance to enteral feeds.
This is the previous slide. When the ratio of pi more than 1 pi, when whole carbon dioxide is produced.
Yes, sir.
That's the thing that you are going towards the overfeeding thing.
Yes, sir.
Sir, like, actually, you see, have you ever seen these being measured? No. Right? I used to work somewhere when there's a separate piece of kit which is attached to the ventilator and the inspiratory and expiratory circuit, and they measured the oxygen going in and the carbon dioxide coming out, and they would automatically tell you the patient needed to automatically give the other. But overfeeding also, the question is, are you giving more carbs? Shidat issue. So if you give more carbs, you will increase. But these are research tools. I don't think they are very useful, or they are very much used in the day-to-day. So the bigger ICUs there, they constantly collect 1,001 data which is continuously being uploaded on the computer, and they look at it periodically, check out papers, etc. But day-to-day clinical management ke liye koi
So day to day, sir, we should go for the clinical examination history.
ওটা এটা শেষ করে না তাহলে day-to-day তোমরা কি করো সেটা আমি শুরু করব।
Sir, how do you calculate this DQ?
Well, actually the machine calculates what is the oxygen consumption and the carbon dioxide production. So in inspiratory limit, it FiO2 একটা দিচ্ছ। তো ওটা ventilation আছে, FiO2% আছে, and expiratory air you are calculating. And the machine automatically gives it to you, right? It was like a monitor placed on the ventilator, and it was giving you all these figures. You have to create it, you have to create CVT as a RRT. In fact, they were trying to properly do resuscitation on the basis of these figures. Resuscitation. So if you resuscitate and tissue perfusion at a body, oxygen consumption bar, carbon dioxide bar, then you have a plateau. So you are looking at the elephant from different sides.
এটার জন্য কি ক্লিয়ার আছে বিজনেস অপশন করে প্লিজ ক্যাচ আউট প্রপার্টি ক্যাচ আউট
There are ways to do it, but I thought that you were doing it on the basis of inspired and expired.
Against like
Oh no, that calorie capture.
next slide. Next slide. Next, I'm discussing the refeeding syndrome. Refeeding syndrome can occur to the patients who are in the first 48 hours if we start with full dose of enteral or parenteral nutrition. As the patient is having high dose of carbohydrates and proteins in the initial few hours of resuscitation, then there is glycogenolysis, also gluconeogenesis and protein catabolism. So the protein, fat, mineral and electrolyte vitamin depletion can switch the patient to anabolic state. So different electrolytes can also go from intracellular extracellular থেকে মানে plasma level থেকে towards the cell they will be more. So in the plasma level or extracellular level the electrolytes will be falling. We can clinically get the hypokalemia or hypomagnesemia, hypophosphatemia. If we get this kind of scenario, then the patient is more prone to develop cardiorespiratory failure or any kind of arrhythmia or any kind of if the hypophosphatemia is there, then the ATP production is impaired. Also, the RBC RBC's oxygen carrying capacity is also diminished. Then this whole thing, also there is, if there is thiamine deficiency, then it can also lead to Wernicke-Korsakoff type of thing. And also there is salt and water retention in the extracellular space. So patient may be developing edema, and the capillary hydrostatic pressure and the colloidal osmotic tension there will be deranged, and the patient will be having increased anabolic state, which is not required or which is rather detrimental to the patient in case of clinical nutrition. This is refeeding syndrome as a whole. So we should stick to the recommendations, like we should not start with a full dose of enteral and parenteral nutrition in the first few 1 to 2 days, and we should at least try to increase the dose in the after the third day, and within the first week we should reach the target, so that this kind of scenario is not. Next, if in critically ill patients for whom caloric needs are measured using indirect calorimetry or estimation during predictive equations, as I have already discussed in the previous slide. So, should we use isocaloric diet or hypocaloric diet? If indirect calorimetry is used, isocaloric diet rather than hypocaloric diet can be progressively implemented after the early phase of acute illness. Hypocaloric nutrition, that is not exceeding 70% of energy expenditure, should be administered in early phase of acute illness. Like as I have already discussed, within the first few 1 to 2 days, we should not give the total energy expenditure according to the patient's energy expenditure. We should start with a hypocaloric diet, and then we should be gradually increasing the diet. Next, after day 3, caloric delivery can be increased up to 80 to 110, but we should not go for overfeeding, like not more than 110% of the measured EE. If predictive equations are used to estimate the energy need, hypocaloric nutrition should be preferred over isocaloric nutrition for the first week of ICU stay. So, when should we apply or implement supplemental parenteral nutrition? In patients who do not tolerate full dose enteral nutrition within the first week, the safety and benefits of initiating parenteral nutrition should be individualized and should be weighed on a case by case basis. Parenteral nutrition should not be started until all strategies to maximize enteral nutrition tolerance have been attempted. Like to increase the enteral feeding tolerance, we should assess why the patient is having different clinical signs and symptoms of intolerance. Like the patient may have nausea, may have bloating, may have repeated episodes of diarrhea. As I have said, we should look for different electrolyte imbalance if the patient is having any. We should look for Clostridium difficile infection if the patient is having any. If there is any stool related complications, whether the stool is abnormal due to any other cause, we should look for the cause. Then after all the strategies to maximize the enteral nutrition tolerance have been already attempted, then only we should go for parenteral nutrition. Parenteral nutrition can be also further divided and broadly classified into 2 types, that is centrally given nutrition or peripherally given parenteral nutrition. In adult critically ill patients, does high protein intake compared to low protein intake improve outcome? The recommendation is during critical illness, like in this kind of ICU state, the stress is moderate to severe stress. So the recommendation is 1.3 gram per kg per day. Protein equivalents can be delivered progressively. The dose is in this recommendation is 1.3. It is a single dose recommendation, but depending upon the stress scenario of the patient, the doses can be altered. If the patient is having no stress, then we can shift to 0.7 to 0.8. Then according to the stress is increasing, we can shift up to 1.5 to 2 gram per kg per day, depending upon the patient's criteria. The statement is physical activity may improve the beneficial effects of nutritional therapy. So what are the optimal combinations of carbohydrates and fat during the enteral and parenteral nutrition? Amount of glucose or carbohydrates administered to ICU patients should not exceed 5 milligram per kg per minute. And administration of intravenous lipid emulsion should be generally a part of parenteral nutrition. Intravenous lipid should not exceed 1.5 gram per kg per day and should be adapted to individual tolerance. As we are concerned about the whole regimen of the clinical nutrition in any critically ill patient, the 65 to 70% of the caloric requirement should come from carbohydrate and fat is 25 to 30% at least. We should not exceed fat in 35 to 40% or more, we should not exceed. And protein requirement is not calculated depending upon the total calorie requirement of the patient. It is calculated differently, and the carbohydrate and fat is calculated differently.
এই যে ক্যালকুলেশন গুলো মানে এটার মধ্যে একটা স্ট্যান্ডার্ড আইডিয়া আছে যে আমাদের যে ডায়েট
Yes.
that person carb খাওয়া উচিত, that person food, that person fat. So depending upon the state of catabolism the patient is,
Yes.
belongs to, we change the protein part.
Yes.
Traditionally, you see, most places will not use your metabolic component, etc. So, the dietitian can look at the patient using the patient's age, the height, the ideal body weight, and the size. We can calculate a arithmetic equation is the standard traditional equation. You calculate the caloric requirement. That is the patient's requirement. You add a factor depending on the patient's catabolic state. So, if it's a trauma patient, it's a burns patient, and patient with sepsis. তাদের ক্যালোরি রিকোয়ারমেন্টটা বাড়বে, প্রপোর্শনেটলি প্রোটিন রিকোয়ারমেন্টটাও বাড়বে। আর ওই নাম্বারগুলো ওই রকম 60 50 20 protein gram per kilo is a standard, and if your requirement is more, then you can 25 to 30% of the করে দেওয়া। মুশকিলটা হচ্ছে যে এগুলো দেবার একটা সমস্যা। এটা তুমি তো ক্যালকুলেট করে নিলে একজনের ধরো 2200 ক্যালোরি লাগে, কিন্তু তোমার পেশেন্টের ফ্লুইড রেস্ট্রিকশনেরও ব্যাপার আছে। orally আমরা যে খাবার দিই, most foods or feeds, it is very difficult to give more than 1 calorie per meal. আর parenterally দুরকম আছে যে there are some preparations which you can give peripherally. They are a little bit less osmolar. If you have to give beshi, that's a centrally দিতে হবে, and then you have to use more of বেড়ে যাবে, কারণ নাহলে ওই ভলিউমে তুমি ওই ক্যালোরি দিতে পারবে না, আর ওই হাইপারগ্লাইসেমিয়া প্রবলেম চলে আসবে। There are special formulations which contain 2 calories per meal. So you have to consider. বিশেষ আর মেইন ব্লকেজ is যে আমরা অনেক সময় পেশেন্টের খাবারের কথা ভুলে যাই। তো পেশেন্টের রাউন্ডে এলো না, এই না অ্যান্টিবায়োটিক চেঞ্জ করো, ইনভেস্টিগেশন করো, সিটি যাবে এটসেট্রা। প্রথম 2-3 দিন পেশেন্টের সিটি হচ্ছে, আল্ট্রাসাউন্ড হচ্ছে, এই প্রসিজার হচ্ছে, people forget. ঠিক আছে? So it is important that we actively at the end of everything else that we do to the patient think about the খাবারের কি হবে। You may take a decision to actually খাবার দেওয়া হবে, but that has to be an active decision. Then next day you revisit it. ঠিক আছে, বাকিগুলো we will come.
Essentially যেটা বললাম till this slide, start feeding as early as possible.
So
Try oral feed. In terms of medically,
Start feeding as early as possible is that key, but there is no rush in the first few days. That is very important. And you have to first, unless তোমার একটা গ্যাস্ট্রিক ক্যাসিনোমা, রুটিনাতে খাইনি, weight loss patient এসে আইসিইউতে ক্লাব করার অবস্থায় আপনি ওরা অপারেট করবে, তাকে it is better to তুমি not on a better feed to build up for etc. But for the normal standard patient, যে ভালো ছিল একটা acute illness নিয়ে ভর্তি হয়েছে, many of them will have a standard, okay nutritional status. The first few days is not important, not that important.
just a hypocaloric one that I understand.
When you start, you can start small. Giving some feed is better than no feed.
Exactly.
The trophic feed concept that it is, that is actually very important, because ota na dile your intestinal epithelial nutritional supply, a lot of it comes from the luminal stuff that you are giving. Sheta na hole that will where খুশি যাবে, and that will cause a translocation and it will drive the inflammatory response. So some feed সেটা তুমি ঝাড় দাও একটুখানি দিলে, and actually এখানে অনেক সময় সমস্যা হয় যে আমরা এই ট্রেডিশনালি বা সাব দিচ্ছে কিনা সার্জন খুশি নয় ফার্স্টে না দিতে না আমার সমস্যা নেই আছে, বাট মোস্ট পেশেন্টস আমাদের তো গ্যাস্ট্রিক সিক্রিশনই কতটা হয়, তো তুমি যদি 20-30 ml per hour feed দাও, that is not going to increase your volume, etc. We all know like this is not correlates with intestinal
So it keeps the skills active.
That's right. It keeps your intestine happy. That is now the most important. So that is it. If you and you have to then slowly build up. And your target is that by 1 week you should be able to give 50% of the patient's total requirement. ঠিক আছে, তার ইম্পর্টেন্ট ইজ যে কিছুটা দিচ্ছি, তারপরে ইউ বিল্ড আপ, এন্ড তারপরে যদি তোমার না মনে হয় যে আমি রিচ করতে পারবো না, then you can give supplement in addition to the enteral. আর প্যারেন্টালিটি ব্যাপার হচ্ছে কাউকে যদি তুমি ধরো এরো পেশেন্ট কিন্তু ভাবে না তার ব্যাকটেরিয়া দিয়ে ইনফেকশন দিলে, কিন্তু সে পাশের দিকে সেটল করে গেল and you are able to go back to enteral or oral, তাহলে there is no difference in outcomes. মানে your parenteral feeding has to go on for more than a week to make a difference to the patient's outcome. So parenteral is like a rush. You can dramatically parenteral nutrition use কমে গেছে unless you are dealing with some special category of patients that are from vagina, micro surgeries, which is short bowel, severe pancreatitis, baba, petechiae, etc. So that is fascinating.
If you require more energy, you have to include lipid more.
Yes.
And if you are going to include lipid more means peripheral thing is going off. Right? You
So
also
it
going
will
to
become
go off.
sugar actually. So it will become hyperosmolar. So you have to give centrally. You can't give peripherally. And you have to do your regular, all those electrolytes and every measurements. You have to make sure that measurements if necessary. You have to do it. Okay.
Next is, should we use additional parenteral or enteral glutamine in rice? In
Partial
patients,
parenteral plus partial. It can be full or partial as well. Enteral can continue and add parenteral.
Correct. Because the integrity of the intestine is common through this.
But parenteral will go for it when we are not able to supply it fully enteral.
But you can give it time. There's
Yeah,
no rush.
that's correct. So TPA or TPA.
so regarding the use of enteral or parenteral glutamine in patients with burns of more than 20% body surface area, additional enteral dose of parenteral or enteral glutamine like 0.3 to 0.5 gram per kg per day should be administered for 10 to 15 days as soon as the enteral dose and enteral nutrition is commenced. When we are starting the enteral nutrition in patients with burn of more than 20%, we should start enteral glutamine also.
क्या है glutamine क्या है?
Sir, glutamine is arginine, omega-3 fatty acids. This micronutrients and essential amino acids we should also supplement this.
Yeah, glutamine is not in the list of essential amino acids, but in their currently state they become conditionally essential. So हमारा technically essential है, but the outcome data is very poor regarding use of glutamine, both enteral and parenteral. Enteral देवा खूब मुश्किल, माने नर्सरा खूब रेले, चॉक-चॉक एकदम intestine of the tubes etc. Parenteral is pretty expensive, so has been used, and in addition to that, a lot of other things have been used. But the bottom line का उपाय कहीं से कि तुम्ही रान्नाघरात chicken soup एकटू खाओ, you will get the benefit. That A, you need to feed. You don't need to feed a lot. Trophic feed is very important. Build up as necessary. Only if you are not able to reach your targets in the week or so, then you can consider supplemental. And in a very small percentage of patients, you will need your parenteral.
In critically ill traumatic patients, additional enteric dose of glutamine can be administered for the first 5 days. And in case of complicated wound healing, the glutamine dose duration can be extended for a longer period of 10 to 15 days. But there are certain contraindications where the patient and additional internal glutamine should not be administered. In cases of patients suffering from liver or renal failure, parenteral glutamine should not be administered. The liver ornithine cycle patient
They generate ammonia actually.
Yes, sir.
That's what-
hyperammonemia
Glutamine is the source of ammonia.
So recommendation 29 পর্যন্ত পার্ট 1 এ বলা হয়েছে।